All right, here we are. Hello, everybody. Sorry we're a few minutes late. Right before we were about to go live, I spilled water all over the keyboard. So that's just the kind of start we're having today. Well, welcome, everybody. I know we have people joining us from several different platforms. This is a really awesome opportunity today. It's the first time I've done a live stream with Dr. Volpicelli. I think it's the first time. We've done lots of Zoom meetings, but I think this is our first live. Is that right?
Yeah, I think so. I think this is our first live stream.
Well, people probably know your face because I have a lot of videos here on YouTube and inside our program, of course, where you're talking about common naltrexone questions and things like that. But we wanted to do a live today to talk about some of the common naltrexone myths, because as we were preparing for this and curating the list, we realized there's a lot of myths out there. I think we have 20 on the list right now, but we're probably
Yeah, 20. Oh
20.
my.
Yeah, we're just gonna scratch the surface today. We're gonna hopefully do more of these series. But for those who don't know you, Dr. Volpicelli, before we jump into the naltrexone myths discussion, I would love for you to introduce yourself for those who don't know who you are and your influence and work in the world of alcohol treatment, specifically with naltrexone. And let me just quickly, for people in the chat, are you guys hearing us? Audio, video, is everything okay? Just let me know in the chat. Okay, sorry. Go ahead. Take it away, Dr. B.
Yeah, so this should be fun. Hopefully, it'll be a series of things that we do together where we can help present information to the general public about naltrexone. But I've been involved with research with naltrexone for, oh my, like 40 years now. And I started out actually working with rats and did a study to show that naltrexone could reduce alcohol drinking in rats. I did that when I was a graduate student at the University of Pennsylvania. And that's where I got my MD and PhD degree. And then I decided to stop working with rats and work with humans. And then during my residency for psychiatry, I actually started the first clinical trial to look at naltrexone to treat people with alcohol use disorder, and started the study at the Philadelphia VA hospital. And we found that the people who got naltrexone reduced their craving and reduced their relapse rates, cut them in half. And the data was used to help get the FDA approval for naltrexone, which occurred in 1994. So I've been involved with naltrexone from the very early days.
Wow.
Yeah. So, and we were excited that maybe this was something that was going to turn around the field, but as fate would have it, a lot of people weren't really prepared to understand that there's a medicine that could help control people's craving and help people in their recovery. And so for the past 30 years or so, I've been really dedicated to try and get the message out to people. And so I'm really happy to have this opportunity.
Yeah, same here. And I'm sure, I mean, you've been in the field clearly much longer than me, but I'm sure you've had people ask you, if this is so effective, why isn't it more well known? And I think some of the myths that we're going to talk about maybe contribute to that. But I wonder if, just to kick things off, and I'm sorry, I'm kind of going off the list, but I just think
That's okay.
it's appropriate for people, because that's the question I get all of the time. And maybe people here listening are wondering, if naltrexone is so effective, I mean, back in the 90s, you were showing that it could help people with cravings and things like that, and it was approved for alcohol. That's 30 years now. Why isn't it more well known and widely used by doctors, addiction doctors or regular doctors?
Yeah, well, first off, I think that's changing, but it's been a real uphill battle. And when it first came out, we were really excited about it. And, I did some television interviews, and it was really in the popular press. There was even they recorded something on Saturday Night Live where they talked about naltrexone. And
Really? Is that
yeah,
still
so
available?
yeah, I had that somewhere. It was Kevin Nealon did one of those weekend updates, and there was a joke about naltrexone right in
You
the
have
weekend
to send
update.
that if you have it. I want to see it.
I don't think they mentioned naltrexone. They just said there's a new treatment for AUD, and
Okay.
I think they said it was arsenic or something like that. But they were referring to the fact that naltrexone just got approval from the FDA, and so there was a lot of excitement about it. And it turned out people didn't use it. And I think that there's two primary reasons. So on the treatment side, a lot of the people who treat people with AUD just couldn't get their minds around the idea that there's a pill that you could take that would help stop your craving for alcohol and help people avoid relapse. It just didn't make sense for them. Alcohol addiction was a defect in character, and the only way to treat it was to address those character defects, typically through something like AA meetings. And so that was one group of people, and they weren't excited about using a medicine. And then on the medical side, a lot of doctors at the time didn't really think addiction was something that was in the purview of medicine. It wasn't something that doctors really treated. And uh, even the doctors who thought that you could use medicines to treat addictions, they were mostly on the opiate addiction treatment side. They didn't think that that was true for alcohol. And so we had a hard time finding clinicians who knew how to use it, patients who knew about it. And at the time, it was reasonably expensive. And so it was hard for people to afford treatment. So those three things all conspired to keep people from getting access to it. But I think all those things are turning around now. A lot more people know about it. Treatment providers are interested in using it. And there's effective ways of getting naltrexone that it's not very expensive. So I think all these things are turning around.
Hmm. Yeah, it's just so interesting that it was more so viewed as, character defects, which I like nobody's perfect. Like if I had to fix all my character defects to get better from alcohol, I don't know that that would have worked for me, but yeah, it's just I think for me it's really encouraging to see that it is being seen more of a medical issue because when I learned about how alcohol use disorder develops in the brain and how naltrexone can help us unlearn it over time, it just was a light bulb moment. It helped me feel that knowledge was powerful. And I think a lot of people feel that way, just like, oh, it's not because I'm a bad person or I'm weak willed or, whatever. It's my brain has changed through repetition. And now I can treat it. I can reverse it.
Yeah, exactly right. It's if you look in medicine, most of the preventable uh, causes of death, it's not related to what we don't know. It's not a question of knowledge. It's a question of motivation. It's that people have a hard time doing the right thing. And I think that that's especially true for addictions is that the addiction takes over our motivational system. And so it's not that we lack willpower or have some other defect in character. It's that the nature of the addiction is that it sort of takes over our craving, our desire to do something, and that becomes the sole focus of what we're interested in doing.
Yeah. So I wanted to ask you, Dr. V, we can start with the myth. Someone's got a question in the chat. How would you like to go about this? Do you want to dive into the myths? Do you want to answer this person's question? It kind of does have to do with one of our myths. It's around the safe upper limit of daily naltrexone, or now they don't say daily, safe upper limit of naltrexone. They're prescribed 100 milligrams a day, and it's not doing much in the large scheme of things. They were on 50
Mhm.
milligrams a day. So one of our myths is that nobody needs more than 50 milligrams. That's a sufficient dose. So maybe we could start with that myth.
Yeah, so the myth is that the correct dose of naltrexone is 50 milligrams. So let me give you a little bit of historical perspective on that. So when I designed the first study, I picked a dose of 50 milligrams. Why did I do that? There is data that that dose was effective in blocking the effects of heroin. So when we did studies and we gave people a dose of heroin, we would see if they got an effect. And so 50 milligrams is a pretty effective dose for doing that. No one really did the good pharmacodynamic studies to say what's an effective dose to block the effects of alcohol. But that was the dose that was used to treat people with opiate use disorder. And so I used that dose to help people with alcohol use disorder. Now, the myth is that that's the only dose that you should use.
Hmm.
And it turns out that there's tremendous individual variability in terms of how naltrexone is metabolized in the body. And by that, I mean that for some people, a 50 milligram dose gives you a really high blood level. And for other people, it gives not a very high blood level. The reason for that is when you ingest naltrexone, the very first thing it does is it gets absorbed by the gut, goes into the veins, and goes to the liver. And that's where between 60 and 90% of an oral dose of naltrexone gets metabolized. And so before it even gets to the brain, for some people, up to 90% of the naltrexone is already broken down.
Wow.
Imagine trying to storm a castle where you're trying to get to the king's quarters, the brain, and you have to cross a moat, but 90% of your soldiers get wiped out just trying to cross the moat.
Yeah.
For other people, it's only 60%. And so 40% of the soldiers are able to go crash the castle. And so there's tremendous individual variability, not only in terms of how much gets to the brain from a given dose, but also how long it stays in your system. And so one of the metabolites from naltrexone is a longer acting metabolite called 6-hydroxybeta naltrexol. And that can last has a half-life of about 11 hours. Naltrexone itself, the half-life is only about 4 to 6 hours. For some people, when they take naltrexone, it's a longer acting medicine. And for other people, it's a shorter acting medicine.
Hmm.
So there's all these factors go into that. There's tremendous variability in what's the right dose. And so if one dose is not working, it's not unreasonable to push the dose up. And so someone asked about 100 milligrams a day. And again, this is one of those myths. I had a fight with a pharmacy who was trying to tell me that I shouldn't write for more than 50 milligrams of naltrexone a day. And then the insurance company didn't want to pay for 100 milligrams a day. And I said, well, I have a little bit of knowledge in the area, and 100 milligrams is a safe dose, and for some people, a more effective dose. And then I pulled out all these references. So, for example, the largest study that looked at the effectiveness of naltrexone was called the Combined Study, sponsored by NIAAA, the federal government. And that compared naltrexone with psychosocial treatments, with Camprel or Camprosate. And in that study, we used 100 milligrams of naltrexone a day. So one of the best, clearest demonstration of naltrexone effectiveness used 100 milligrams. And so there's clinical data to show that 100 milligrams works fine and is safe. I can say a little bit more about the safety of naltrexone, and it turns out it's an incredibly safe medicine, and it's virtually impossible to overdose. There is actually a case study where there's a woman who was prescribed 50 milligram naltrexone tablets. And she was struggling with opiate addiction, alcohol addiction, and she wasn't doing very well. She had some crisis in her family, and she was really discouraged. And so she took all 30 naltrexone tablets all at once. Oh my God, this is terrible. So it must have destroyed the liver and that sort of thing. No, didn't do anything. Person had nausea, felt sick for a day or two, did not have any bad effects on the liver. Actually, it sort of blocked her craving for alcohol and opiates. So for the next 2 weeks, she had no craving at all. So it was effective, but it didn't have any bad effects otherwise, except for nausea. And so naltrexone is a very safe medicine. We can talk about the myth with respect to liver dysfunction later, but it's safe and effective, and you need to really play with the dose to find the right dose that works for you.
Do you typically ever put people above 100 a day? Have you taken them to 150 or higher?
I've gone as high as 150, but not higher than that.
Okay.
And we can talk about, besides individual variability, is there certain types of people who tend to need higher doses? And ironically, I find women seem to need higher doses than men. And I don't know how to explain that, but normally you think women need smaller doses because they're smaller. But actually, in my clinical experience, often I find that the 100 milligram dose works better than the 50 milligram dose for women.
That's so interesting. So this individual has a follow-up question, which it's not one of our myths, but I think it should be around the timing of the dosing, because something I hear from people is, oh, my doctor said it doesn't matter if I take it at morning or night, like just to take it once a day, anytime. And their question is around that. Like, the Sinclair Method. They're currently taking it around 1:30 p.m., they say, after showering, but their alcohol intake is at night. So is there significance to the dosing? Is it a myth, dosing and timing? Is it a myth that it doesn't matter what time of day so long as you take it?
Yeah. So if you want to get the maximum effectiveness of naltrexone, you want to take it about an hour or two before drinking. That's when you're going to get the peak level of naltrexone in your system. For some people, again, it has a short half-life, which is about 4 to 6 hours. So if you take it at 1 o'clock and you don't drink until 5 o'clock or 6 o'clock, half of the naltrexone that you took is already going to be metabolized if you're one of those quick metabolizers. So you're not going to have as an effective dose in your system. So you might find that you get a better effect by timing the dose of naltrexone that more closely correspond to when your craving is high or when you're likely to drink.
Okay. Okay, so one of our myths, going back to our list, it kind of correlates with this, that you can't drink on naltrexone. It's dangerous. I see that comment at least once a week on my videos. So what do you say to that? It's dangerous to drink on naltrexone and you can't drink on it?
Yeah, well, the short answer is it's not dangerous to drink on naltrexone. And we can talk about the myth if you should drink if you take naltrexone or not.
Yeah.
That's one of the things that people have talked about, that the only way it's effective is if you pair alcohol with naltrexone. That's the only way it's effective. But let me again go back from a historical perspective. That in the early days when we used naltrexone, the only other medicine that was FDA approved to treat AUD was a medicine called antabuse or disulfiram. And that worked by blocking the enzyme that metabolizes alcohol. And so one of the metabolites of alcohol is a molecule called acetaldehyde, which is basically a poison for your body. It's probably responsible for a lot of the bad medical effects of excessive drinking. But on the short term, increases in acetaldehyde makes you feel really sick. So you get nauseous, you feel lightheaded. When it level's really high, it can actually cause changes in your cardiac output. You can get fainting. You could actually die. So very serious side effects if you combine alcohol with disulfiram. And that's the mechanism of how it works. If you take disulfiram, people know not to drink or they're going to feel violently sick. So it works by punishing you for drinking. So when naltrexone came out initially, people confused naltrexone with antabuse and thought that's how it works, by making you sick. But it's a completely different mechanism. It works by blocking the reinforcement from alcohol and also reducing the craving, the obsession, the desire, the motivation to drink. And so by itself, it doesn't do very much to you. It doesn't affect you very much. But when you take it and you have high craving for alcohol, it reduces that craving. If you take it and you drink, the drink doesn't create the need to have more drinking. It blocks that vicious addictive cycle. That's the mechanism of how it works. It doesn't make you sick. It just makes you not interested in having more than one or two drinks.
Yeah. I love how you describe that without naltrexone, when a sign of AUD is that one drink creates the need for the second and the third, and it's just chasing that endless buzz all night long. And I can certainly relate with that. But with naltrexone, after a while, I just became more of a normal drinker where the first or second drink actually made me satisfied and there was no need to keep going. Yeah.
Yeah, I mean, what you say is really important for people to understand the fundamental um, cardinal feature of addiction. What addiction is that by doing something, by drinking alcohol or taking opiates or shooting, snorting cocaine, whatever it is, engaging in the behavior creates the need to do more of it. It's a vicious cycle. Instead of, when I'm hungry, a natural hunger, a natural motivation is when I'm hungry. If I eat, I get full and I'm less interested in eating. So eating turns off the hunger drive.
Yeah.
And there's other things in life that I love, But when I engage in them for a while, I get tired of it and I move on to the next thing. It satisfies my need. But for addictive activities, addictive drugs, addictive other activities, engaging in the activity creates the need to do more of it. And so you get stuck in a loop, a horrible addictive cycle loop, where drinking creates the need to drink more, and that fuels more craving, and the craving increases the desire to drink more alcohol, and you're stuck in a horrible, endless loop. And what naltrexone does is it blocks that. It blocks that addictive cycle. So you drink the alcohol, but it doesn't increase your craving for the next drink. You're satisfied. So it gets at the core cardinal feature of what addiction is. And when people understand that concept, then the idea of using naltrexone makes perfect sense.
Yeah. Yeah, and the satisfaction is the perfect word for it. Just feeling like how you eat after a meal and you're full and you just don't want more. The thought of eating more might sound even a bit repulsive. That's what it did for me, and I've heard from others with alcohol. But for some of us, that's an adjustment, maybe for all of us, even because we're used to getting that euphoric, giddy buzz that we're just chasing all night long. And instead, after a while, we feel just like tired and yeah, we don't want another drink. We just want to go to bed. And I know from you, that's what a normal drinker feels like. That's why they can stop after a couple because they're just tired and they're not incentivized to keep going. But that's definitely an adjustment on naltrexone to have that effect after a couple drinks instead of that, like, keep the buzz going type of feeling.
Yep. Yeah, exactly right.
Okay. So we're getting some questions in the
Oh my.
chat.
We may not get around to
I know.
myths. We have so many questions.
Well, seriously, I think I can tie all of these to myths, so maybe
Okay.
that's the way to do it. Elizabeth is asking, how does eating food along with the medication affect its effectiveness? And actually, I have a question around this because I've heard doctors say don't eat to help naltrexone be absorbed better, and I've heard other doctors say do eat. So, what's your opinion on how does eating food along with it affect the efficacy?
Yeah. So again, we have to look at the pharmacokinetics of naltrexone. So when you take it orally, it goes to the stomach and it stays in the stomach. And depending on how quick substances from the stomach leave the stomach and go into the small intestine, that tells you how quickly the naltrexone is going to be absorbed, because most of naltrexone is absorbed in the small intestine. So when you eat and you take naltrexone, it delays the rate in which naltrexone gets to the small intestine. So it delays how quickly it gets into your system. So if you take naltrexone with food, it'll have the good effect of you won't get as high a peak level of naltrexone. And people who get side effects, sometimes that's a strategy to avoid side effects. But on the other hand, if you're looking for a good peak, it's better to take naltrexone without food, because you get a nice spike in the level of naltrexone in your blood. So if you're using it in a targeted way, often it's better to not eat for, again, another 60 minutes to 90 minutes after you take the naltrexone. And by that time, it's already absorbed. And then you can eat. And then the same thing for alcohol, the alcohol gets absorbed in the small intestine and the stomach. But if you drink alcohol on an empty stomach, it's going to get absorbed quicker. So that's going to give you a bigger buzz. If you take alcohol with food, it slows how quickly the alcohol gets absorbed. And so you get more of a mild effect. You get less of a peak, and it takes longer to get to that peak.
Okay. So yeah, that makes sense. I always recommend it was like a game changer for me when I started eating before I was drinking on naltrexone. The combination of naltrexone and the food just helped the medicine work better. I know sometimes for us that can be a habit to break because we want to drink on an empty stomach if we've been doing that for a long time, but just that little trick, eating before drinking, like enhanced the effects of naltrexone in my experience.
Yeah, and again, it slows how quickly the alcohol gets absorbed, so you're going to get less of that euphoria from drinking,
Hmm.
and less of that addictive cycle, if you will.
Yeah. Interesting what Lowell says. A friend with multiple alcohol relapses was told by her doctor not to drink while taking Nal, or it would make her sick. Her doctor said that. Her doc. Yeah.
Well, so that doctor assumes naltrexone works like what?
and abuse.
Ant abuse. There you go. That's where it comes from.
Okay, this person asks, how should we dial in our personal dose? At first, I found myself very irritable. I also had that side effect, by the way. Found myself very irritable with 50 milligrams, so I've been doing 25 milligrams. It seems to be working, but should I try to go back to 50? That kind of goes back to the dosing question. I mean, I know some people on 25 and they've stayed at that, but what's your thoughts on that, Dr. V?
Yeah, I mean, if the 25 is working well for you, then that's fine. I would just stick with that. Again, there's so much individual variability in terms of what's the right dose for people. And again, that goes back to the myth. The right dose is the dose that works for you. That's the right dose, not 50, not 100. It's the dose that works best for you.
Yeah. Okay, and then this question, thank you, click to preview. Since I vape nicotine and drink alcohol at the same time, is that kind of a double whammy regarding the effective dose of naltrexone compared to alcohol alone? And this is something I've been meaning to ask you because I saw a study where naltrexone could potentially help nicotine addiction. I don't know if you know anything or if you've seen that study, Dr. V, but
I,
yeah, what are
I
your thoughts on this?
Yes, no, I know. Stephanie O'Malley has done a lot of research looking at
Okay.
nicotine and alcohol, and she found that people have nicotine addiction, nicotine use disorder. That for some of them, naltrexone actually helps to reduce relapse to smoking.
Hmm.
But here's an interesting finding: that turns out drinkers who also smoke tend to have a good, robust response to naltrexone. So it looks like there's some sort of interaction between nicotine and alcohol that they have sort of synergistic effects, that you get a bigger buzz when you smoke or whatever. And if you take naltrexone, that's really helpful for that group of people.
Huh.
So if you're a smoker and a drinker, naltrexone is likely to be particularly helpful for you.
Hmm. Okay, very interesting. Okay, another myth I want to go to, and yeah, I'm curious what your thoughts are on this one, where people believe that drinking has zero pleasure on naltrexone. If you take naltrexone and drink, there's no pleasure to be had at all. What do you say about that? My personal experience isn't that exactly, excuse me, but what do you say?
Yeah, so that's a really good question, and there's two ways to look at it. Number one, how specific is naltrexone for blocking the reward, the enjoyment, the euphoria from alcohol? And the answer is it's pretty specific for blocking opiate receptors, so drugs that work through the opioid system. It's effective in blocking, but it may be helpful for nicotine. We just mentioned that. It might be helpful for other behavioral addictions like gambling, like sex addiction. There's some data for that, pornography addiction. And so it looks like it's really helpful for things that are mediated more by the endorphin system, if you will. Now, alcohol as a molecule is a complicated molecule. I call it a promiscuous molecule because it affects so many neurotransmitter systems. One of the important ones it affects is the endogenous opiate system, the endorphins. And for many people, that's the reason why they get stuck in that addictive cycle that we talked about. And by blocking that, it helps people limit their drinking so that they don't want to have more than one or two drinks.
Yeah.
But alcohol affects other neurotransmitters, like virtually all of them. But one of the important ones that it affects is the GABA system, which is the system that has to do with slowing down your nerves, sedation, maybe relaxation. And so for some people, when they drink, they tend to feel more relaxed. And the naltrexone does not block that effect of alcohol. So people can get that kind of reward.
Mm.
And then there are some people who maybe they've been drinking for a long period of time and your body has adapted to the alcohol. And so you develop tolerance to the alcohol, but also you get withdrawal if you were to cut down or stop drinking. And then the withdrawal feels really uncomfortable. You get the shakes. Sometimes you feel nauseous. You can even have withdrawal seizures. It can be really uncomfortable. And drinking alcohol will block the withdrawal symptoms. And naltrexone does not affect alcohol's ability to do that. So you can still get a reduction in withdrawal symptoms by drinking alcohol, even if you have naltrexone in your system. So in that way, the alcohol is still rewarding. We would call it negative reinforcement because it takes away something unpleasant, but the naltrexone doesn't affect that.
It kind of reminds me of a question you answered for me a while back. There might be a video on it, I think, where you talk about naltrexone's impact on pleasure in general, because people fear that on naltrexone they won't experience other pleasures. And you described it like the pleasure center is like a symphony and not a single instrument. Did you want to speak about that a little bit since it is related?
Yeah. So one of the things another one of those myths is that people equate dopamine with reward. I think somebody even wrote a book about that.
Are you talking about Dopamine Nation?
Yeah, yeah,
Okay.
Anna Lemke. So, I had discussions with her about this sort of thing. And she makes some really good points, but I think it's misleading to think that increases in dopamine is the same thing as reward. That you can get increase in dopamine when you're nervous about something.
Hmm.
The increase in dopamine often reflect attention and motivation. That people can be motivated to avoid something that's unpleasant, and the dopamine system gets energized from that. So the dopamine system is not a one-to-one correspondence to joy, to reward, to pleasure. And when you think about it, it's our pleasure system is much more complicated than just one neurotransmitter system. That sometimes it's really pleasant after a stressful weekend just to relax. Probably not dopamine. Other times you're bored, you need something exciting, dopamine. So there's these neurotransmitter systems interact with each other. And also, I like the idea of a symphony because if you look at dopamine as sort of like the percussion section of the orchestra, it adds energy, drama, and that sort of thing is exciting. But if the whole symphony was just drums, it would be boring. It wouldn't be pleasurable. So sometimes it's the back and forth between the strings, the horns, the percussion section, and you tie them all together, and that's what makes something feel pleasurable. It's the back and forth, the way they interact with each other, the timing, the rate of increase, the rate of decrease. All these things function together to give you joy and happiness.
Okay. Yeah. I hope that helps people understand that a bit more because I know it's a concern. So back to the chat. Couple more questions for you, Dr. B.
Sure. Oh
Um,
my.
John's asking, I started naltrexone October 20th, 2024, and followed Sinclair Method until November 18th, 2024, so about a month, at
Mhm.
which time I decided to stop drinking altogether. I've been alcohol-free since then with little to no urge to drink. Is it safe to stop naltrexone now?
Yeah. So if you don't have craving for alcohol and you're doing well and you're not drinking, then it's okay not to take the naltrexone. But I would suggest that if you go into a situation that's a high risk situation, then it might not be a bad idea to take a naltrexone prophylactically, not with the intention that you're going to drink. You don't have to do an extinction trial, and we can talk a little bit more about that. But the naltrexone can help block the craving. And I'll give you some examples. I have a patient that I've been seeing for, oh my, about 6 years now. And he had a terrible time with his alcohol addiction. His wife almost left him. He lost a job. His life was falling apart. He went on naltrexone, cut back his drinking, stopped drinking altogether, lost the desire to drink. And he hasn't had a drop of alcohol now in 5 years. But he still takes naltrexone as needed. And so he told me the other day, no, and not the other day, actually a couple of weeks ago, his daughter uh, got engaged. And so at the engagement party, they had an engagement party. He went up to have a toast, and so he knew he was going to be around alcohol. He was actually going to give the toast, And so he took naltrexone ahead of time and was able to give the toast without any desire at all to drink. And I have to say this for people who don't understand about treating addictions and how naltrexone works, that I have other patients who haven't had a drop of alcohol to drink in 5 years, but they don't take naltrexone. They never took naltrexone, but they went to meetings, they worked really hard with psychosocial treatment, and they white knuckled their way to being abstinent. And then sometimes they go into a situation where there's alcohol available because they learn to avoid people, places, and things at AA meetings. But now, after 5 years, they decide they're going to go to a wedding and they're around alcohol. And the craving comes back just like it did before.
Yeah.
And naltrexone seems to help block that. And having gone through a lot of experiences with naltrexone in your system, it seems to extinguish these cues associated with drinking. So now they walk into a wedding and they have no desire to drink. It's not that they work hard not to drink. It's not that they're avoiding situations to avoid drinking. They don't want to drink. They don't care to drink. It's not something that even bothers them. They don't feel like they're giving up anything in their life.
Exactly.
They just feel good that they can enjoy the function, and the fact that there's alcohol there is completely irrelevant. It really has lost any significance for them. For someone who suffered from addiction, that notion makes no sense. How can alcohol become blah, bland, when it's like one of the most important things in my life? I have patients who pick the restaurant that they go to have dinner depending on who serves the best drinks.
The strongest drinks, that was my motivation.
The strongest drinks, yeah. So everything sort of revolved around that. They wouldn't drink, but then their spouse was going to be away for the weekend. Oh, here we go, it's party time. That it was still in the back of their mind that they wanted to drink, but they were able to suppress that urge, sometimes with difficulty.
Mm-hmm.
Well, with naltrexone, it's not suppressing an urge. Recovery is more than just not drinking.
Yes. That's why I adore you, Dr. B. You get it. Like, you speak to the heart of the issue, and it's so rare to encounter not only, well, people in general, but physicians who just understand that. I clearly remember going to an addiction conference, talking with a big wig in the SoCal area who ran a bunch of treatment centers and was asking about naltrexone. And he's like, we've known about that for decades. We just think abstinence is best, like poo-pooing it. And I was like, what? Like, that's completely overlooking the root of the issue. Yeah, technically abstinence is best because it's safest, but what's going on in the brain when someone's white knuckling that sobriety? And if they get 2 years sober and then they binge and relapse, it's like, that's putting them at huge risk. So yeah.
You know what's the best? The best is when you can give a toast at your daughter's wedding reception and not have to worry ahead of time that you're going to drink. That's the best. The best is where it doesn't become an issue for you in your life.
Yeah.
That's the best.
That's
the best
true healing.
Drinking or not drinking. The best is recovery where it becomes irrelevant. That's the best.
Because alcohol is still controlling you. If you go to a function like that and you're like, oh no, am I going to relapse? Like, I better like stand in the corner and leave early. Like, that is not freedom in my view.
Exactly. You're absolutely right. That freedom is the ability to do whatever you want when you want to do it. That's what recovery from addiction is. It's freedom. It's not that you're not drinking, you're not using a drug, that you're abstaining from something. It's that you don't care to use it. And some people still care to use it. Some people will take naltrexone and have 1 or 2 drinks and are perfectly happy with that. I have a patient who I've been seeing now she was from the early days. I mean, like 2-3 decades now.
Wow.
And she would take naltrexone faithfully, but she still liked to have a glass of wine before going to bed, probably for its sedative effects. And, before that, 1 glass would turn into 5 glasses and she'd be hungover the next day. But on naltrexone, it was like 1 glass. And she's been doing that exact thing for like 30 years. It's never escalated, but she hasn't stopped either. and she's doing perfectly fine.
Hmm.
She's doing perfectly fine. And that's recovery, even though it's not complete abstinence.
Yeah. I have to follow up with John's question here when he asked about being on naltrexone for a month, basically, and then quitting after that time, doing the Sinclair method for a month. That is rare to see someone within a month just feel like they're done and they're better and they're moving on. Like, what do you say to that? How does that happen to people like John?
Well, again, let me give you some data. So I've looked at this question. Again, there's no rules how long you have to be on naltrexone, but I can give you some data from research studies. And so when I did a study, and the original study was that you would stay on naltrexone for 3 months, and then we stopped people. And it showed that during that 3 month period, it reduced craving, it reduced rate of relapse, and was very effective. But then I also looked at people when they ended the study to see what happened. And what I found was after people finished the study on the next 3 months, a fair percent of them wound up relapsing.
Hmm.
So I did another study where I kept people on naltrexone for 3 months or 6 months. So after 3 months, they went on to placebo. And what I found was that the people who went on to placebo after being on naltrexone for 3 months, they did worse than the people who stayed on the naltrexone.
Hmm.
So they had a higher chance of relapsing. So even though they didn't know that we switched medicines, we switched them from naltrexone to placebo, they didn't know that we switched them. They did worse. So their craving increased and they wound up relapsing at a higher rate. And so at least 6 months, I would say. My clinical impression is that you should be on naltrexone for about at least a year. And here's why. That I like to give people a whole year's worth of holidays to get through where they have the experience of going through the holiday without drinking. Was it last weekend we celebrated the 4th of July? And for many people, the 4th of July is a time to get together with friends, have picnics, and drink. What did they say? Someone said he liked to have a fifth on the 4th.
That's funny.
So it was one of those holidays that he always drank. He'd always get together, go down the shore. In Pennsylvania, you go down the shore, go to Atlantic City, go to New Jersey shore, and they would sit around and enjoy fireworks and drink. And that's what he would do every year. And so even though in June he didn't have much craving for alcohol, I would be worried that on the 4th of July, when he's around his buddies and stuff, the chance of relapsing would be high, and he would have an episode of drinking without the naltrexone, and that could lead to a bunch of bad consequences. Like you would want to drink the next day and the next day. And so I like to have him go through a 4th of July without drinking to prove to himself that he doesn't need to drink. And also in his brain, it helps to extinguish that association between 4th of July means drinking. You want to extinguish all those associations that when a TV commercial comes on, and people talk about alcohol, that no longer remind you that you need to drink. So it extinguishes all those cues associated with drinking, and that takes some time for that to occur.
Yeah.
So I think a year is a good period. I have patients who've been on it for a very long time, and some people do well with a short period of time, and some people just take it as needed from the beginning and do great with that. So again, there's huge individual variability, and you have to find the right treatment that works for you. But I would say is if you do experience some craving after just being on naltrexone for a month, which would be an outcome that I would not be surprised about, then I would recommend that you would stay on the naltrexone longer.
Yeah, and it makes me think of someone who I'm working with in our program, and then this is not the first time I've seen that, but they progressed on the Sinclair method, were basically hardly drinking anymore at all for like months, having easy alcohol-free days, and then life throws a curveball, super stressful event happens, and they noticed that they just defaulted back to drinking to cope with it. And they said, "I don't even really want to drink, but this is just how I've always coped with hard things." And they hadn't had that difficult of an encounter since being on naltrexone for about a year. So yeah, just any thoughts on that or anything you want to say as to maybe why that's happening?
Well, it's again, there's a lot of individual variability. That's all. That
Yeah.
you need to find what works.
Yeah, and, like, they said that, the craving isn't there anymore, but it's just, like, the memories maybe of defaulting back to drinking in response to that.
I didn't want to get into it today, but I've been taking a peek at some data from the questionnaire that you're doing, and so I have a whole lot to say about that. But I'm holding back to say anything. But the whole notion of craving and naltrexone response turns out to be a really important issue.
Hmm.
But we can talk about that some other time. So
Maybe we'll do a live just to dive into that data on the findings. Yeah, and by the way, thanks to everyone. If you are here and you filled out the survey I sent, thank you. And if you want to fill it out, please reach out to me because we're still collecting, feedback from people who've done naltrexone and the Sinclair method or other ways of using naltrexone. Kind of like this is a myth that I just encountered yesterday, and I've encountered it before, and it's a little bit related to the length of time someone is on naltrexone. The person called me and said that their doctor was willing to prescribe naltrexone, but only for 30 days. They wouldn't prescribe it beyond that. And they were like, why would that be? Like, when you look at the research and how it works, it doesn't make sense to only offer it for 30 days. So why do some doctors, I've seen 30 days, I've seen 90 days, but some doctors aren't willing to prescribe beyond that? Do you know why that could be? What myth is perpetuating that?
well, I'm not sure why the doctor only wanted to do 30 days, but excuse me one second.
Yeah.
Sometimes I'll prescribe a medicine only for a limited period of time because I want to make sure the person keeps coming in to see me on a regular basis. So, for example, some programs will say you need to be on this medicine for a year. So they write a prescription that lasts for the whole year. And then there's no reason for the patient to come back and talk to the doctor. And I find that that doesn't work very well for patients.
Yeah.
And oh my goodness, a whole nother session here. But let me say this, that when I work with rats, there is no problem with people, with the rats, getting naltrexone in their system. I know because I injected the naltrexone right into their body. But for people, I have to depend on them taking the naltrexone. And not everyone's consistent with doing that. And if you're not consistent with taking naltrexone, it doesn't work.
Mm-hmm.
So part of treatment is to help engage people to start the naltrexone and take it regularly. And so in my program, we've designed a psychosocial treatment that's designed to help improve people's motivation to stay on the naltrexone and take it on a regular basis. And I know for people who are part of Thrive and part of other support groups, the combination of naltrexone with that psychosocial support turns out to be a key component for getting people to engage in treatment and to stay consistent with taking the medicine. And
Yeah.
then if people struggle with that, they can get the support of the community to say, look, I had trouble being consistent with taking naltrexone, but since I've been taking it consistently, it's been helping me get better and giving people hope and encouragement. And that helps to get people more engaged in treatment.
Yeah.
And so sometimes a doctor may say, I don't want to give you such a long prescription that you don't need to see me regularly because I want to see you back here in a month and see how things are going, where we can have a conversation about adjusting the dose because there's a lot of individual variability, adjusting maybe other medications that you're taking. We can monitor your progress. So it turns out one of the real important reasons that people are adherent with taking the medicine is when they can see that there's progress in their recovery.
Mm-hmm.
I have patients who come back after a month and they say, I don't think it's working. And then I ask them, how's your craving? Well, it's reduced in half. How's your drinking? That's way down. How are things going with your spouse? That's improving. Why do you say it's not working? Well, I still have weekends where I drink too much. I said, but look at the progress that you're making. And then say, okay, well, then I'll give it another month. So here's somebody who's ready to quit But by having a conversation with me and seeing the progress that they're making, it gave them encouragement to do it for another month. And they continue to make progress. And eventually they get to a point where they lose the craving for alcohol, and it becomes something that they can take it or leave it.
Yeah. Okay.
So maybe that was the reason why it was only 30 days.
Yeah.
Or wanted to see it because he needed to charge you for an extra visit. I don't know.
Yeah.
It could be that too. But in my practice, it's to get people to be engaged, to titrate the dose, to go over side effects, to correct
Yeah.
any myths and misunderstandings that they have, and to get people to keep staying on the medicine and keep getting better.
Yeah, and I wasn't clear if it was like 30 days is all I'm gonna give you and I'm not even willing to refill, or if it was more of what you're saying, that the doctor wanted him back.
If it was 30 days and they didn't want to give you a refill, then they don't understand how naltrexone works, and you need to
Okay,
find
yeah.
another doctor.
Okay. So I see a couple more questions, and this one I'll get to yours, Lowell, about, but I want to go to Elizabeth first because it's kind of related. Where you just said if you don't take naltrexone, it doesn't work. Elizabeth is saying, "I'm curious if you've been on naltrexone for a while and are drinking less than before or not at all. What is the danger of drinking without the pill for a single occasion?"
Well, there's, and again, I was looking at the questionnaire, so I have some really interesting data to share with you. But it turns out that when you look at people's outcomes, that there's a really tight correlation between good outcomes and people taking the medicine consistently. The very best results are the people who take it every single time before they drink. You get less good outcome if you take it most of the times before you drink. And so if you drink without naltrexone, you're likely to get that pleasure again, and the drinking is going to increase the need to have another drink or another drinking episode. So one time where you drink without naltrexone could put you in a spiral where it turns into like a full-blown relapse.
Mm-hmm.
So that's number one. Number two, we're trying to teach the brain that the cues associated with drinking no longer predict drinking. And so that is an extinction trial. And then there's also behavioral extinction. And that's what David Sinclair talked about, where the behavior of picking up a drink and drinking is rewarded by the alcohol. And so you get an effect where now your behavior is rewarded by getting the pleasure associated with the alcohol. And it turns out when you give what we call intermittent reinforcement, where sometimes you get the reward, sometimes you don't get the reward, that makes it really difficult to extinguish a behavior. So that's why it's bad in that respect. It's your brain gets confused. Is alcohol rewarding or not rewarding? Sometimes it's rewarding, sometimes it's not. And it always tries to figure out, what happened? Why is it not rewarding in this situation? And it just makes it much harder to actually extinguish the cues associated with drinking and also the behaviors that are rewarded by drinking.
Yeah.
But having said that, it's not the end of the world. Okay. Don't spend a lot of time beating yourself for that. Don't feel discouraged. It happens all the time. You just get back on the horse and do your best.
Perfect. So Lowell's asking, any feeling on whether naltrexone helps with stimulants like meth?
Again, a really good question. So most of the stimulants work by directly stimulating an increase in dopamine, which, as I said, increases the motivation and the focus on getting more dopamine. So it's pleasurable and also increases the focus for it. Naltrexone mostly works at opiate receptors. Now, it turns out when your opiate receptors are stimulated, that has the effect of increasing dopamine, which again gets you on that cycle where the drinking increases the need for more drinking. And so the naltrexone should not work for stimulants because they are sort of, we call it downstream to where dopamine is having its effect on motivation. Now, having said that, there may be some data that it's helpful for those sorts of things. And we're finding that these medicines, including the GLP-1 agonists, that sort of thing, they seem to to work across like all addictions, and we don't quite understand how that all
Hmm.
works. But we do know the neurotransmitter systems have a very much an interrelationship with each other. So if you affect one, you might affect the other. But it should not be very effective for stimulants. But for some people, it might be helpful. And certainly there are some people, actually, I did a study where I had patients who were dependent on stimulants, on cocaine in particular, and alcohol. So they had the combination. And naltrexone was effective in that group.
Hmm.
And for people who use both drugs, that often they would use the cocaine to sort of get the dopamine system going, and then they would use the alcohol to sort of chill when they would start getting too paranoid. And then when you block the effects of alcohol, you took that away. They didn't like the cocaine as much.
Hmm.
And then there was other people who they would start drinking, but then when they started getting tired from the alcohol, then they use the cocaine to sort of overcome the tiredness. And then when you block the effects of the alcohol, they didn't have a need to use the cocaine anymore, because the cocaine was just there to help reduce the sedative effects from the alcohol. So
Hmm.
naltrexone was especially helpful for that group.
Interesting. Okay. Very interesting. Okay. Well, we just have a couple minutes left. Maybe we can wrap up with this question here where Tiffany is asking, what are your thoughts on Vivitrol? And for those that don't know, that's the injectable form of naltrexone. And I know you have thoughts on that, Dr. V.
Yeah. Again, worth a whole nother.
Yeah, we could do an episode on that.
So actually, I was involved in the Vivitrol study that the company did to get the FDA approval. So I wasn't one of the authors, but when we conducted the study, I was advising the company about what's the right dose. So if you looked at the original Vivitrol study, it had two doses. It had a 190 milligram dose and a 380 milligram dose. And it turned out the 190 milligram dose did not work very well. It was only at the higher dose that it worked. So that's number one. Number two, that I suggested that they combine the medicine with that psychosocial program that I talked about, designed to help improve people's adherence and compliance. And so I supervised all the clinicians, and they had pretty good treatment adherence, and they wound up showing a good naltrexone effect. But then the third thing about the study that's really interesting is that I suggested that if you're going to do like a 6-month study, the outcome that you want to look at is return to heavy drinking. And if you have people who start out drinking at the beginning, some of them may continue drinking because the alcohol doesn't take away the sedative effects or the withdrawal effects.
The naltrexone doesn't take that away.
Yes, I'm
Yeah.
sorry. Yes. And so if you want to get cleaner results, make sure you have everyone detoxed first before you look at the Vivitrol. It just is going to give you cleaner results. Well, so people designed the study, ignored my advice on that. But I said, at least go back and use a pre-planned comparison where you're going to look at those subjects. And thank God they did, because when they did that, they found that most of the effectiveness of the Vivitrol was in those people who had 3 days or more of abstinence before they got the Vivitrol shot.
Hmm.
So if you want to look for clean results where you compare naltrexone versus placebo, it's good that you start everybody sort of at the same place in which they don't have any alcohol in their system and they don't have any withdrawal symptoms. Now, who is Vivitrol good for? So that's probably the question that you're really asking. Why would someone use Vivitrol as opposed to targeted naltrexone? And here's my answer. When I conducted the very first clinical trial, I noticed that I would talk to patients who would drink on naltrexone, and they came back and they said, Doc, I have one drink and I don't feel like having another drink. I was at the bar, somebody, poured me another shot of whiskey, and you know what? I left half of it at the bar. I've never done that before. And I said, great, it's working. And they said, not great. I didn't even get any buzz. So he was mad. So he said, how about if I take the naltrexone during the week, so I don't get my wife pissed off at me, but on the weekends, at least I can go out with my buddies and drink with them, and do the tailgating and stuff. I said, no, 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 you don't get the point. He goes, yes, I do. And that's what he did. And so even though naltrexone worked the way it's supposed to, he messed up my data because he would have relapses on the weekend. He would have heavy drinking days on the weekend. So he was,
Drinking without naltrexone on the weekend.
yes, he would
Okay.
stop the naltrexone a day or two before the weekend so he could enjoy the buzz. And he did that on purpose. But he didn't want to drink too much during the week because that would upset, his boss and his spouse.
Yeah.
So that's how he used it. So now there are some people who on Monday when they come in to see me, they swear up and down, that's it. They quit, had a bad weekend, they're never going to drink again. And then by the time the weekend comes around, their motivation wavers a little bit. It's like, you got that alcohol staring you in the face and you're thinking that would really hit the spot. And this is where Vivitrol is really helpful because you come in on a Monday and I give you the Vivitrol shot, and then that takes away your vote when the weekend comes. And it turns out that it's an important psychological principle that when the reward for something is right there staring you in the face, often you make decisions which are not in your long-term best interest, but make you feel good now.
Yep.
When it's a decision for what you want to do 5 days from now, often you say, 5 days, I'm going to go on the diet. I swear, going to eat healthy. I swear, I'm going to the gym. So you make decisions that are in your long-term best interest, but don't necessarily make you feel good in the moment.
Right.
And that's true for human nature in general. When I go to bed, I say, tomorrow I'm going to wake up early. So I set the alarm. Then the alarm goes off. It's like I keep hitting the snooze button. So what the Vivitrol does is it takes that decision and helps you make decisions based on what's your long-term best interest. So it takes that vote away when the alcohol is staring you in the face. And that's where the Vivitrol can be really helpful. So people's motivation wavers over the course of a week or a month. They only have to make the decision one day a month.
Yeah.
To come in and get the shot, and then they're good for the whole month. They have it in your system. So that's where Vivitrol is especially helpful. And there's some people who just don't like the idea of taking pills every day.
Mm-hmm.
It's not because they don't want to. It's just that they get busy, their schedule, or whatever. So they'd rather just get a shot for something and not have to worry about it. So it's great that we have various forms of naltrexone that we can make available for people. That you can take a long-acting injection, lasts for a month. You can take the pill daily. You can take it in a targeted way, just when you have the craving, or if you want to have a situation where you take the naltrexone, but you don't want to drink too much when you do drink. So there's a variety of ways of taking this very flexible medicine.
Yeah. And so I'm curious to follow up. I know we're at time, but just for people who want to use naltrexone to drink less for the Sinclair method, is Vivitrol an adequate, does it work the same as the tablet? Like if someone's willing to be compliant, but they're taking it an hour before versus someone who's on Vivitrol, are they going to have similar results? I know everyone's different, but could they be an apples to apples comparison?
Well, theoretically, if you get a Vivitrol shot, you should have enough naltrexone in your body to block the rewarding effects of the alcohol. So so if you drink, having had the Vivitrol shot, you should get an extinction trial. Now, for some people, the whole idea of planning an hour or two ahead of time that they're going to drink and then taking a pill, that sort of makes you more mindful that this is going to be a drinking episode. And maybe that's helpful, that you have to think about it and take some proactive steps.
Yeah.
So that may add a little extra benefit from taking it in a targeted way. But for other people, they don't know when they're going to drink. They go out to a restaurant and they don't believe that they're going to drink. And then somebody orders their favorite, bottle of wine, and they say, I'm just going to have a sip. And they didn't take the naltrexone ahead of time. And then they're off to the races. I would like to see a form of naltrexone where you could take it sublingually and it gets into your body faster. And so you go to the restaurant and you say, well, I'm going to take it and you're good to go in 30 minutes. You don't have to
Wow,
wait for an hour or 2 hours.
that would be cool.
So something like that might be a good.
So you're gonna start working on that, is what you're saying? No.
Not allowed to talk about it yet.
Oh, I was joking. I didn't know if you actually would or not. Well, this hour has gone by really fast. I think we only got through 3 of the myths on our list of 20, so we've got more to do. But I just want to thank everyone for the really good questions because they wove into our myths. And we will be back again, I think, in just a couple weeks with another live. So looking
See if you can
forward.
do another 2 myths.
Yeah. We'll make it through the first myth. There's so many good questions though, and yeah, it's knowledge is really power for people to know about how to best use naltrexone because it is a versatile medicine for alcohol use disorder. So, Dr. V, for people who want to learn more about you and your work, tell them where they can find you.
Well, yeah. So I have a website, the Institute of Addiction Medicine.org. And I think we're setting up all kinds of good social media stuff on the Naltrexone Alliance. And I have a Substack that I write for. So join my Substack.
Okay, how do they
Dr.
find your
Joe
Substack?
Volpicelli on Substack.
Joe Volpicelli?
Yeah, Dr. Joe Volpicelli on Substack. Yeah.
Okay.
Yeah. So if you're interested, send me an email. I'll send you an invitation or something. So
Okay.
you can check out the Substack.
Yeah, and if anyone doesn't know how to reach him, you can reach out to me and I'll give you his website or contact info. And we formed a Naltrexone Alliance at the leading of Dr. V, like almost a year ago now. And it's really, well, can you tell them about the Naltrexone Alliance? And then I'll tell them where they can find us on the social medias.
Yeah, so Katie is helping us, and we're bringing together people who have the like-minded desire to help teach people about naltrexone and bring naltrexone to the world. And so we're planning to help teach clinicians, bring it to the general public, and advocate for the use of naltrexone. And we brought together a lot of really wonderful people from all walks, scientists, clinicians, people who run treatment organizations, and people with lived experience. And we're all working together to try and help get the word out about that. And we're going to put together some good social media stuff and see what we can do to help spread the word. And something is happening. I can feel it that things are changing now. People that I said, well, no one's heard about it, and people say, oh, I've heard about it. But now we have to get people not just to have heard about it, but to understand it, how it works, and how to use it properly. We still have some work to go on that. But for anybody who has got a good response, we need to get the word out. We need to tell people about this. And if it was some other medical disease, it'd be easy to get a spokesperson to say, I took it and I got better. But when it comes to alcohol use disorder, people get better, and they don't want to share the information with people. But it's not something to feel bad about. It's something to be proud about, that you had this challenge and you're able to take some steps to get better from it. So you need to give people hope and encouragement that they can get better too.
Absolutely. I mean, I saw on the CDC saying that 1 in 3 Americans drinks excessively. So it's not it impacts a lot of people who are on the spectrum of alcohol use disorder. And I think it's for us to not have so much shame and stigma around it. Like if people realize, like the people I work with, and probably you too, Dr. V, looking at them 99% of the time, you would never know they struggle with alcohol. They're successful, wonderful human beings who have a life and a family. They've just got this thorn in their side. And so it's not.
I have to share one more story.
Yeah.
Then we can quit for the day. But when I set up the Volpicelli Center, so the Addiction Treatment Center, we have a string of offices, and so my next door neighbor was upset that addiction treatment program was going up next door, and he did financial advising to people who would visit him, would need advice in terms of how to spend their money and invest their money. And so he would complain to the head of the the management, the property management company, to say, oh, Volpicelli's patients, they just sit around and smoke cigarettes and leave their cigarette butts all over it. And they didn't. They did. And what he didn't understand was I was seeing the same folks he was seeing. It's just, they visit him and then they come around to see me. It's the same people, the same people. You know, people don't understand that this affects all areas of society. And as people get better, you can't tell that they had an alcohol problem. They look just like anyone else. If somebody walked into my waiting room, they might see a couple over here with a young child, a successful business person over there, a doctor over here. It looks just like any doctor's office.
Yeah.
And that's how we treat it. And that's what it is. So, it's please, get the word out, help support people in the recovery, let people know that there's an effective way to get better, and we can reduce that stigma.
Yeah, absolutely. Well, this has been a really great and helpful conversation. Thank you so much, Dr. V. And just by the way, we are building out Naltrexone Alliance social media channels. So you can find us on YouTube, TikTok, Instagram with the handle Naltrexone Alliance. It's just getting started, but we're going to be sharing some of these lives and clips from our lives that I'm doing with Dr. V. So